Yes.
Jesse, how about your audio? Jesse Forbes, can you hear us?
I've heard from, so I can hear you.
Hello.
Hey, can you hear us again?
Jason, I can't hear you. Is that just on my end?
So I can hear you. You can't hear me?
I can hear you, Jason.
I'm just important where settle down and pay attention.
How about now, Mr. Forbes? Everyone just bear with us for a minute. He's the work group chair, so we got to get him going here. Mr. Forbes is going to log out and log back in to try to correct the problems. Just bear with us. Mr. Forbes, he's still connecting. Okay, Mr. Forbes, it looks like you're back in the meeting. Can you hear us now? Your mic is muted if you can. Mr. Forbes, are you able to hear us?
Let me try it now. Can you hear me?
Yes, I can. Are you able to hear me?
Yeah, I had to dial in. I don't know what was going on with my computer. Sorry about that.
Okay, well, we can hear you now, so we're good to go. So we have all the work group members here, and as well as several members of the public. And we did have a reporter ask for access also. If there are any members of the press online, I would ask you to hold your questions and send those through our office communications for a response. Be much appreciated. We are having this work group meeting to continue discussion of Rusty Williams's proposal from the last meeting. Mr. Forbes, I would suggest that you again set ground rules for public participation. If you want to wait till the end, like last time with 90 seconds each, that's fine. We'll facilitate that. Or if you want to do something different, that's also fine.
No, I think that makes sense. If we could ask for the public, if they just kind of stand by and let us discuss a little bit about where we're at, and then we'll certainly make time. So I think it's really important and appreciate any public members that came on tonight and took time out of their own personal lives and schedules to be here. So we definitely want to hear from you. But I would ask that we just hold any of those comments until the end, unless there's anyone feels differently.
Okay. Once Mr. Forbes does ask for public input, I would ask that members of the public utilize the chat box to enter their name, and we'll call on you as you're entered into that list and go from there. We do have two guests, Senator Takubo and also a regulatory guest. I would ask those folks to, Louis Koski, I would ask those folks to quickly introduce themselves for the benefit of the board members. Mr. Koski, can you go first?
Sure, thank you. My name is Louis Koski. I'm the Chief Operating Officer for Metric LLC. It's a seed to sale vendor that is supplying the seed to sale tracking software here in West Virginia. Prior to that, I had spent the bulk of my career as a regulator in the state of Colorado, much of which was spent in the early phases of cannabis rollout for both medical cannabis and for recreational cannabis there in early 2014. In fact, at that time, I was the director of the Colorado Marijuana Enforcement Division as we were promulgating a lot of the first sets of rules and working through some of the original framework around recreational cannabis, health and safety issues, home cultivations, et cetera. So I've been involved with cannabis policy in one way, shape, or form since middle of 2010, and I haven't celebrated a birthday or slept much since. So looking forward to talking more with you all about it.
All right. Thanks, Louis. Dr. Takubo, can you give a quick intro?
Sure. Thanks, Jason. Thanks for having me. Tom Takubo. I'm currently serving as the Senate Majority Leader. Been in legislature now for about 7 years here in Charleston, but I'm also a home critical care physician. And so happy to participate and give you any insight from the legislative view.
All right, thank you. All right, Mr. Forbes, I'll turn the meeting over to you as the work group chair.
Thanks, Jason. I think what might make sense, and I think I'd like to get into our guests here and get their input just as quick as we can, but what might make sense first would be, Rusty, if you're there, if you could maybe just kind of update us on the proposal that you have. And I know we had sort of discussed this at length during our last subcommittee meeting, and then we made the report to the full board that we wanted to invite these speakers here. and kind of get more of a study of exactly what we're asking for as the medical cannabis program begins to roll out. But maybe if you could just kind of give us an overview of what your proposal is and what you think makes sense, and then we could move into the speakers that were so gracious to come talk to us tonight.
Absolutely. Actually, thank you, Mr. Koski and Senator DeCubo for joining the discussion tonight. Basically, to me, since I was put in the position of patient advocate, I've met with and talked to a lot of patients, both in illegal states and in states where they have legal access to cannabis. And, I'm really worried that once our program gets up and running, that a lot of folks are going to be essentially priced out of their medicine. I can speak from my personal experience. When I was going through cancer and chemotherapy treatments, my chemo regimen was pretty aggressive. I went 5 days a week for 6 hours at a time, and then I was off for 2 weeks, and that was considered one round. I was fortunate. I had a safety net, had family that lived close by that I was able to stay with, until I was finished with my treatments. And I'm really worried about folks that don't have those safety nets. I think we need to have a way, for people that, whether their barriers are financial or transportation issues, our dispensaries are going to be pretty spread out throughout the state. And I'm worried that we're going to have people who could potentially be a couple counties away from, accessing at the dispensary. And I just feel like allowing patients to grow small amounts for personal use, we're not talking about letting people grow fields of cannabis and, starting empires or anything like that. I'm talking, a handful of plants, something that could be easily managed. We want it to be regulated. If caregivers are going to be able to grow for patients, I would like to see, the cannabis that they are providing for patients have to go through the same testing protocols that cannabis sold in dispensaries would have to be, would have to be subjected to. But to me, this is all about facilitating better patient access. And without going too deep into it, one of the stories that, I met with a woman who, her daughter, really rare form of epilepsy. She started having like just crazy seizures. They went through all of these different medications. She said that they literally had tried every medication that was available. Nothing seemed to work. And it got to the point where, her primary care physician recommended brain surgery, like an exploratory brain surgery, right? Somebody on her team, her medical team, recommended that she go out to Colorado and try cannabis to see if she could get any relief from that. She did. She took her daughter out, and they spent 6 months just trying products, and it come to work out for her. Cannabis really changed the quality of her life. Now she lives in a legal state, and not only does she cultivate cannabis for her daughter, but as part of her daughter's therapy, her daughter actually takes care of the plants. They're shooting a documentary about this family right now, and it should come out later, maybe later this year. But she brought something to the table that I think is important. When we're talking about home grow, when I was going through all of my treatments, I can't imagine a more hopeless feeling than, going through chemotherapy and dealing with cancer or whatever. I can't imagine what that little girl, at 13 years old, dealing with seizures and just that quality of life. And just the act of cultivating that cannabis and growing the plant that is going to, she is going to use as medicine is also part of her therapy. And, it's changed her quality of life, not only physically, but also emotionally and mentally. And I just think that it's an important part of the puzzle. And if we are truly going to create a medical cannabis program in West Virginia that facilitates the best patient access, home grow should be a part of that.
Thanks, Rusty. I appreciate the thoughts and the comments. I think if we could, maybe we could move into Mr. Koski, if you're still there with us. If maybe you could give us sort of your experience having already gone through this process somewhere else. We're always looking for ways to not have to reinvent the wheel. So if there's any insights you might have, I think it might make sense to sort of segue into that right now.
Yeah, I think I can cover a couple of points, and then I think maybe I can get some questions. Hopefully, it'll be enough to spur some questions, and we can have a little bit more of a deeper conversation. I think I'll start by kind of just addressing Rusty's comments first. I've been doing, like as I mentioned before, I've been in this space for a really long time, primarily focused on government's response to cannabis. In fact, I've also taught a class at the University of Colorado on how government responds to cannabis legalization. I never really get tired of hearing stories like Rusty's and some of the stories that he brings up, because it kind of helps remind us that behind all the commercialization, there are a lot of patients and a lot of patients that get some, report that they're getting good use from the product and getting good results. I think as I've heard many of those stories as well, Rusty, I hear a lot about price. I don't know how you feel about this, but I also hear a lot about the type of product from patients as well. And so much as that price is certainly important, but so is getting the right strain. And so I think a lot of patients feel really strongly about either who provides that cannabis for them or a particular strain. And a lot of times once a commercialized market that's either medical and recreational, sometimes those strains may not be as popular and may not be offered. And so, I think patient advocates are oftentimes really advocating not just for price and access, but availability of the product that seems to work for them the most. So Rusty, I don't know if that resonates with you or not, but that's something that I've heard as well, kind of just adding to what I've heard from other patient advocates.
Absolutely. And to that point, the young lady that I was just talking about, that's cultivating her own cannabis as part of her therapy, that's part of the reason why they found a strain that really works well for her.
Mm-hmm.
And what they found was the consistency within the dispensary system. Like if you went into one dispensary and you bought, a specific strain, and then you go into another dispensary and you think you're buying that exact same strain, there could be differences in the terpene profile and in the cannabinoid profile to where, she wanted to grow her own to make sure that they were going to keep a consistent product. So
yeah,
I've definitely heard that.
Yeah, so that's thanks, Rusty. I appreciate you adding that in there, and so that's real consistent with what I'm hearing too. So what I've noticed on the home grow situation is there's usually about 15 problems. Please don't make me list them all, but there's usually about 15 problems you're trying to resolve, and they come from various stakeholder groups. So I think we've kind of outlined what you're likely to see from a patient advocate stakeholder group. And, in addition to Rusty's voice, if there's any interest in hearing more honest brokers and constructive voices from the patient advocacy group, I'm always happy to make some additional introductions to anybody on the committee as well, to kind of expand on that voice. Now, having all that said all that on kind of like from the patient advocate perspective, having home grows does invoke other new problems for different types of stakeholder groups. So I can kind of hit on a few of those, and hopefully, again, like I said, they'll spur some more questions. So one area that I have a little bit of experience that kind of first came to my mind, and I was reading, I think it was House Bill 2550 was a piece of legislation, kind of try to get a sense of maybe what your legislature was working on. I think I saw like 10 plants per patient. Patient had to have a card. 5 of them could be in veg and 5 could be flowering, something along those lines. That kind of helps provide a kind of like a basis to have the conversation and start to frame where some of the other problems might come from. So I'm gonna start with maybe lower levels of government and work my way up on how problems kind of manifest themselves. Keeping in mind everything Rusty had to say, which sounds like we're pretty consistent on, what I've seen at the local jurisdiction, if there's not an allowance for either like regulatory promulgated rules or at the legislature, sometimes local jurisdictions have a hard time distinguishing residential grows that are legitimate compared to the ones that are not. And sometimes they're almost like given an unfunded mandate from the state to be able to regulate these. So chances are good if you put this into legislature and you didn't really earmark who was going to be responsible for conducting some of that regulation that Rusty was talking about, it defers down to the local jurisdiction, and local jurisdictions usually handle it in the form of land use type of doctrine, which one can take a little while to get through. Two, a lot of times agricultural cultivations conflict with a lot of residential restrictions. So for local jurisdictions to be able to put some form of reasonableness on how the plants are cultivated in a residential area, or a residential lot, whether it's indoors or outdoors, are we going to allow for that? Or if it's indoors, do we let them grow within 2 feet of the ceiling? Or is that a hazard? I mean, there's all sorts of things on the land use side that when we're dealing with this at a state level, sometimes it's easy to forget some of what the local jurisdictions have in mind for being able to ensure that they're safe. There's certainly fire hazards. There's also concerns about mold and mildew and those types of things. Now, I understand. I'd love to talk more too about Rusty's proposal for testing. But there's some things that have to be worked out at the local jurisdiction. So typically I see local associations for municipalities and counties, working really hard, to contribute to a proposal similar to Rusty's, to give some availability or some access or some availability for local jurisdictions to take into account concerns that they might have about residential grows. I'll give you another example just from the local jurisdiction that's probably worth mentioning. And when I read 2550 for West Virginia, which I don't believe is alive still, but just kind of using that as kind of a launch off point for conversation, I noticed that it's 10 plants per patient. So if Rusty and I were roommates, we could grow 20 plants in the residence. So again, local jurisdictions are going to want to be able to try to have some way to be able to control the size of the cultivation, especially if it's going to be in a residence, near drywall, near young children, such like that. So how that all gets resolved is varied by the number of local jurisdictions that exist in the states. So maybe I'll pause there for any questions anybody has, or I'm also happy to yield to the senator if I'm taking too much time.
Any of the other board members have questions? I'll ask, if not right now. Mr. Koski, in your experience in Colorado, did home grow roll out initially, or is that something that happened over time? And maybe what have you seen in other states since? I guess that's one of the questions we have, is our program at this point is not live. It's close, and hopefully it's going to be live very soon. But one sort of question mark we had at the last meeting was, is this something that we should jump in and make a recommendation on now, or do we need more data as we see the program roll out? And are there any pitfalls you could advise us on that?
Yeah, so let me address Colorado first, and kind of how that rolled out. So it was a constitutional amendment in 2000 that essentially opened up the door for small cultivations for patients. It was intended to be similar to what we're talking about right now in West Virginia. The biggest difference then is that the political narrative around cannabis in 2000 was considerably different than 21 years ago than it is right now, obviously. And what happened there was, in the absence of a commercial marketplace, the home grow or the residential or the patient cultivations really over time started to take on the appearance of more of a commercial operation. And then ultimately they started opening up stores, and there was no doubt that it had kind of morphed into, still a lot of small home grow cultivations by patients and caregivers, but there were some pretty large commercial operations that came from that. Part of the reason for that is there wasn't a lot of specificity around what the requirements were. For one, it was in a constitutional amendment, so it's always, a lot more challenging to create more law and regulation around that if the constitutional amendment doesn't really allow for it. That was similar for us. There's a lot of ambiguity around that. So the bottom line in Colorado is it started with home grows. I mean, I think that's different in West Virginia in a lot of ways. One is that it's 21 years down the road, and the public narrative and sentiment around cannabis is changed considerably. It's much more of an accepted practice, for one, and two, you all are starting with a commercialized marketplace, and thinking about having the home grow cultivations. Now, not having an opinion on that one way or the other, quite frankly, I'm agnostic on home grows and pretty much everything around cannabis. But what I would tell you is that, a lot of times, I think, especially in the nascent nature, what you might hear from members of the cannabis industry is that they would have concerns about how they might have to bear the burden of all the regulatory constructs, and maybe be operating at a bit of a competitive disadvantage to those that are not as regulated, which typically that kind of what happens with home grows. And that's not to say I didn't hear Rusty say that this should still be regulated and still be tested. I'm just letting you know that that's one of the dynamics that we hear a lot, is that, and I've seen a lot, is concerns about the competitive disadvantage. And I will tell you, when in a lot of states, if you look at states that had largely unregulated cannabis industry thriving in the state, and then you start a regulatory framework, it's, first of all, it's exponentially harder to do, and it took, I think 10 years off my life roughly to do that. But it's also, but one of the aspects of it that makes it so difficult is the fact that the new regulated community tends to operate at a competitive disadvantage to unregulated actors, in so much that they have to pay application fees, they have to pay licensing fees, they oftentimes in medical programs still have to pay taxes, not always, but sometimes they have to put in cameras, they have to do testing, they have to do a lot of things. So the regulatory burden is high enough that the competitive nature of it is such that industry, or the commercialized aspect of it, usually raises the concern about those competitive disadvantages they're at the front end. Now, I don't know how many patients you all have as of, I think February is when you all started accepting patient registration. So I don't know exactly what the numbers are vis-a-vis how many cultivations and stores that you're having, but it's something to think about, as you're trying to on-ramp and really build a credible regulated cannabis program. The extent that you have another segment of the industry that's either less regulated, that has the potential to grow or scale in size, that will be a concern likely to the industry interests.
Yeah, that's a concern that brought up last time. Is concern that I had was not really knowing, how this industry is going to roll out and how it's going to be viable. Are we setting them up at the outset if we recommend and ultimately the legislature would approve home grow? Is that something that's going to negatively affect the industry? And then other patients that aren't able to home grow for whatever reason, are they going to have a bigger problem getting the product, or a more expensive product as a result of it, or things like that? And so I appreciate the comments. It looked like Rusty was trying to jump in. I'm sorry if I jumped in ahead of you.
Well, I went out to Colorado and I talked to some patients and I talked with some folks out there. And it's my understanding that when Colorado first allowed home grow, they were allowing caregivers to grow 99 plants per patient. So what the caregivers were doing, they were getting warehouse space, and they were getting 5 patients and growing 500 plants and putting them out there, and they were creating those problems. It's my understanding that they acknowledged that was the issue. They've since brought the plant count back to 6 for personal use, and I think that sort of eliminated the problem, because one of the things I don't think we're going to let patients grow 5 plants and they're going to turn that into an unregulated industry. I just don't see that happening. I think that more often than not, I mean, we live in an instant gratification society. If you give people the option to go to the dispensary and buy their products hassle-free and come home and medicate safely and legally, they're going to do that. The only people that are going to grow, in my opinion, are the folks that either don't have a choice or, you know, your occasional hobbyist. But as far as, you know, people growing a handful of plants and putting that back out in the market, I don't think that's really going to be too big of a concern. And if they would do that, you know, we already have laws where, I mean, if you get caught selling cannabis right now, you know, you are going to go to jail. So those, you know, those penalties are already in place. And I just don't know that when it comes to allowing, you know, a cancer patient or somebody dealing with MS or, you know, lupus or something like that to grow a handful of plants, I'm not sure that we have to, you know, overregulate it. I think that if we had provisions in place, you know, kind of like Virginia, where they just went legal, you know, starting, I think July 1, anyone 21 and older can grow 4 plants as long as they're out of public view. And their language was very vague. It said something, as long as measures have been taken to keep it away from minors. Now, they didn't specify any of that. I know that as I've been pushing the home grow idea to the West Virginia legislators, I've always, you know, tried to include something, you know, if there's minors that live in your house, you know, if you have people that are 21 and younger that live in your house, your plants would have to be kept behind lock and key, whether that was a closet, a spare bedroom, you know, a small greenhouse in your backyard, whatever the case may be, you know, as long as it was kept behind lock and key away from minors, I think that, you know, that would definitely be something that we should do. But when it comes to the regulating of the actual product, what I was saying earlier, I think that's more of a caregiver situation. You know, if I'm a caregiver and I'm growing cannabis for 5 patients, the cannabis that I dispense to those patients, I feel like should be tested, you know, for molds and heavy metals and pesticides and that sort of thing. So, you know, I want to make sure that when we're looking at this, and I get it, I've actually spoken with some folks from industry, and it's about 50-50. You know, 50% of them have absolutely no problem with home grow. I've actually talked to some folks who are dispensary permit holders here in West Virginia that said, no, if we can get home grow, we'll actually have classes in our dispensaries to teach patients how to grow properly. You know, we can provide them with the clones, so they're buying safe, you know, safe tested product. So I think there's a way that we can do this without over regulating it. But you know, I don't want to be scared of, you know, allowing patients to grow a few, because right now I do think that this needs to be part of the conversation as well. We have a mandatory minimum in West Virginia. If you're caught cultivating cannabis right now, if it's 1 plant, you're going to go to jail for a year. So I'm worried that we're going to have patients who have gone and they've had their condition certified, they have their card, and they're legally allowed to use medical cannabis in the state of West Virginia. But maybe it's a financial barrier or a transportation barrier, whatever the case may be. If they get caught growing a plant that the state says they're legally allowed to use, they're going to lose their freedom. And in a lot of cases, through civil asset forfeiture, they could lose everything they've ever worked for. And I just don't think that's, you know, that's something that we should be subjecting patients to.
So Rusty, just, you know, listening to you kind of work through some of those policy mechanisms. Those are policy mechanisms that I have seen, just as you have, across the country, that various jurisdictions use to try and solve some of those problems. And again, you know, I'm kind of like considering myself here tonight to kind of help define the problems as people see them, and some of the policy mechanisms that I've seen. And you just nailed a number of those down. You know, like trying to figure out what's the right plant number. How do you address some of the access issues to minors, et cetera. Those are all like really good things to consider as alternatives to solving some of those problems. One thing I did want to mention to you about Colorado is that I wish it was only 99. We actually, when it was just a medical program and on ramping into the adult use, there really wasn't a limit on the number of patients. Yes, the number of plants, no. And we had a lot of doctors that were providing plant counts as high as 200. And so it was after recreational, probably closer to like 2015 or 16, where we worked on reducing that to 99. And everyone just kind of like, so you know, like stating problems at various levels of government, the 99 number was like really referring to federal law in that at 100 plants, it becomes a sentence enhancer. So, patient advocates were, if they were advocating for a number, they wanted 99 because that would be the most they could grow, and if the federal government intervened, that it wouldn't be a sentence enhancer. So they tried to reduce the limit down to 99, which is just a bit of trivia too that I give to my my students in my cannabis class at CU, and they usually takes them most of the semester to figure it out. But you guys know right now, so if anybody hits you with that, you'll know 99 is the federal sentence enhancer. So,
Lewis, this is Jason. I just want to throw out a technical question real quick. Rusty had mentioned testing plants that may be produced through home grow. I just don't know that that's financially feasible. To your knowledge, have any other states implemented that provision for homegrown materials?
yes, the one I'm most familiar with is my home state of Colorado, because I helped on that legislation, and we also helped kind of solve the tracking issue on that. Because there's again, the regulated industry is tracked all the way from seed to sale. While there was a large push for testing, and I could totally understand why patients would want to test for potency or for pesticides, those types of things. It can be cost prohibitive for a small home grower, and for the same reason Rusty was talking about, price is obviously an issue for a lot of patients, right? So actually doing that testing can be somewhat prohibitive. The other challenges, I'm going to put my regulator hat on for a second, and kind of tell you what my position was back in Colorado, which was supported by the administration at the time. But we were really concerned about what would happen to the testing facilities if they got a failed result. So for example, and ours was a little different in that, I'm assuming that 2550 again is kind of like the benchmark that we're talking about, where a patient can only grow for themselves. In Colorado, a lot of the caregivers and patients were allowed to distribute elsewhere, which may or may not be a problem. I haven't seen Rusty's plan or some of the other recommendations in West Virginia. But what happens is when you test cannabis, you don't test everything, right? You take a sample of it out, you take it to a testing facility, they test it, they give you the results. If you had something that was really dangerous, you oftentimes wouldn't be able to, other than notifying the caregiver, you had no way to take that cannabis out of the stream of commerce. So they could get that result and be like, thank you, and still continue to distribute it to other patients, regardless of what the test result is. So that's one challenge. So to answer your question, like a little bit more directly, Jason, is yes, other states have addressed that, but they still kind of face all those same issues I was just talking about. How states are trying to figure out, okay, how do we feel about harvested cannabis entering into the regulated framework, even if it's just for testing, without knowing what the source is. So that was a concern. And then two, what do you do when you get a failed result? So you'd actually have a government agency getting a failed test result without the ability to efficiently be able to take action to protect the public health.
Thank you.
It sounds like the cost issue, and Jason may have been getting at this from a administrative cost, but it sounded like from you, Mr. Koski, that in your experience, some of these states are that cost would be passed on to the grower, right? They would have to bear the burden of whatever that cost is if that was put in for testing. Is that what you've seen?
That's correct, Jason. I'm sorry if I misunderstood your question. Yeah, it's usually the whoever it is that's producing the product that pays for the testing.
I'm kind of looking at it like, I grow a garden, right? Like I grow my own vegetables. And if I want to grow tomatoes and bring them into my house and make ketchup for myself to eat, that's fine. It's all good. I don't have, I can do that without issue. But if I want to make a tomato, I want to make a ketchup here to serve in local restaurants, then there's quality control measures that just like everything else that are in the restaurants. When I'm talking about testing, I don't think that we necessarily have to test the cannabis that a patient is growing for themselves. I'm pretty much just talking about, the caregiver situation. If you're growing cannabis to go to someone else, I do think that, we've got to work out some way to make sure that, the cannabis that the patient's receiving doesn't have mold and doesn't, have pesticides and those sort of things. Because what patient, not just patient access, but the quality control is crucially important to me. You don't want to give somebody who's going through cancer or something, cannabis that has mold in it and potentially make the situation worse. So I'm not sure what that would look like, but I do think if we are going to let caregivers grow for some, for someone else, there definitely needs to be some sort of testing protocols in place.
Thanks, Rusty. And does anyone else have any questions for Mr. Koski, any of the other board members? If not, maybe we could move over and hear from Senator Takubo. Anyone else have any questions?
Yeah, this is Joe. The question I have is, okay, what are there states where, are there states where they don't have home grow, where pricing is not an issue, like where access is not an issue for the consumer? Are there any states that do this right and they still have a product that's affordable for for just about anybody to access? Any comments about that? And I'm asking Mr. Koski.
Thanks. Rusty might know a little bit more about this than I do. So you talked about price. I think if you forget about home grows for a minute and just recognize the fact that there's been a cannabis industry in West Virginia for a long time before the medical program, in whatever form it was in, patients have been buying from that segment of the industry, whether it's kind of like more of a larger grow, or a residential grow. They've been buying from that industry and they've been paying for it. So whether you allow home grows or not, if there's an interest in providing a more regulated framework and like arguably a safer product through the batteries of testing that you all approve, you have to be able to do that in a way that competes with the illicit or unregulated marketplace. And so what we have seen across the country is states be able to do that efficiently enough to be able to be competitive. And I'm talking about mostly like just the medical states, to be competitive with pricing, not necessarily beat it, but certainly to be competitive with the unregulated and regulated marketplace. I can't think of an example of a state that doesn't allow for home grows. I know there are some, but for whatever reason, I'm drawing a blank on that. But when you think about pricing, it's sometimes a little easier to tier it as unregulated, allowances, illicit, and then the regulated marketplace. And it's all about, especially when you start bringing on adult use, it's all about being able to be price competitive in the marketplace. Because you're hoping to shift buying patterns such that people are purchasing from a regulated environment where the product is safer because of the way it was cultivated and all the requirements that go around that. I don't know if Rusty and I would agree on this, but I think, if you were to regulate home cultivations the same as you were commercial operations, it would probably make it cost prohibitive for the patients to be in compliance with that, or it would certainly increase the risk of that.
Mr. Koski, in your experience, do you see the seeds for the home grow coming from the regulated industry? Is that, because I guess, getting to the point of, the safety of it, as a lawyer, I can tell you some horror stories of people that have gotten tainted marijuana and done some really unbelievable things that had other drugs in what they thought they were purchasing because they were buying street drugs. Is in your experience with these other states, would the home grow seeds that the patients get and then cultivate themselves come from the regulated industry so that there would be a safer product?
Well, so what I would say for certain is you don't want to prohibit patients from being able to buy immature plants to use in their home cultivations. Because if you do, then the only place they can get them is from the illicit market. So you're almost compelling them to get them from, what could be potentially, an unsafe source if it's not subject to the health and safety regulations that are in the regulatory framework. There's a lot of nuance to that, but by and large, what we've seen is states allow for it and not prohibit it. I haven't seen. I have to think about that. I don't know that I've seen any place mandated that it comes from the regulated marketplace, but it's entirely possible that that's the case. Did I answer your question, sir?
Yeah, I think so, and I appreciate that. Does anybody else? Joe, did you have any follow-ups to your question, or anyone else have any other questions for Mr. Koski? I mean, any other board members?
Yes, Mr. Koski, this is Dr. McMillian. In my discussions with patients who certify and have discussed with me the possibility of home grow, and then also in the conversations that I have had with operators in the state, my concern or question to you would be, in states that have home grow as a rule, where patients must purchase seed or saplings, small grows from those operators. I mean, what time frame are we looking at as a industry standard? Would those things be ready in West Virginia for patients to do now? I mean, certainly, we keep talking about patients are not getting care and patients don't have access to medical cannabis, and there's nothing ready at this point, and hopefully soon we'll have dispensaries open. And but at the same time, in order for patient safety to be a point of advocacy from the physician standpoint, how long does it take? What I've been told is it takes a couple of grows for those owners to get to a point where they were able to get seed, get small grows to patients, in a manner of which they would be able to participate and grow their own. I mean, if that's what we're talking about, and if that's what we're talking about, we're talking months, year down the road, that this being able to something that can roll out to patients. And I mean, you understand my question?
Yeah, I think I do. I do think that could be a challenge. I've seen it done by operators a couple of different ways. I mean, I think, especially states that have strong medical programs. I've also noticed that a lot of the commercial operators were former patients themselves. So they have a real genuine interest in wanting to serve that community. So they've made a lot of accommodations to be able to sell plants, small immature plants out of the storefronts. Now there's some regulatory things to consider there. So for example, we've seen states that just simply don't allow plants in the stores potentially. So you'd have to have some allowance for stores to be able to sell like an immature plant that's less than however many inches, right? Doesn't make a lot of sense to sell mature plants. So you probably want to sell them when they're seedlings. It's actually better for the plants too, from what I'm told. I'm not a botanist by any stretch, but there's a couple of ways to do that also. I mean, again, allowing for it. But you're not wrong in thinking that this could be a challenge from some of the stores. Again, not knowing what the total patient population that's registering, how quickly stores are going to operate, what kind of demand there is going to be at the stores for patients. It may be a little while before stores and cultivations and infused product manufacturers get a real handle on what their inventory requirements are going to be to supply the various demand that they have for the cannabis products that you all allow for. So I do see that being a challenge. I think the other challenge that is probably maybe a little bit more prominent and more practical than it is regulatory is, I mentioned earlier that the patient groups tend to be pretty artisan in what type of strain they're looking for. So one of the challenges they may be facing is actually finding the exact product or strain that services their ailments the best or treats their ailments the best. And so it might be challenging for them to get that from the commercial market.
Dr. McMillian, this is Jason. I'd like to address your question also. I don't know that what we're discussing here is going to have much of an effect on the speed at which patients will be able to obtain products, simply because of the way the industry's rolling out. We're still going to have that build out time, the time for them to become operational, and the time for them to grow plants, no matter to what level of maturity that plant may be when it's sold. And also, we have the legal aspect also. You have to remember what we're doing here is discussing this issue and possibly making a recommendation to the legislature, but it would still take that legislative action to put any of these changes into place. And of course, that would take time also. And I have a feeling we're going to have a functional industry before that could possibly happen.
Right. And I understand that. I just wanted to get his idea based on, time frame wise. It's not going to be that patients are going to be okay and here they've grown 10 plants already. Now that they've got a card, they're okay with what they've grown. You see what I'm saying? Patients are obviously already growing some of these products on their own illicitly. And so, I don't want patients to think that, okay, homegrown is okay. Well, once you get your card, what you've grown from home over the last 6 months is not what we're calling homegrown.
That would certainly not be the case now with patient cards. And, of course, depending on how any changes to the law were written, it's hard to predict.
As far as accessing the seeds and, accessing clones, just like Mr. Frame just said, this is all going to require legislative action to take place. So the dispensaries are going to be open, they're going to be up and running. But one of the things that I think that if we are proactive on this and if we spend the time and not just make a recommendation, but make a recommendation with some pretty detailed parameters, we are a seed certification state as far as the hemp industry goes. And, maybe there's some way that we can marry those two together and make West Virginia a seed certification state in the medical industry as well. So, that's an option. That's something that we could potentially include in possible legislation.
Thank you, guys.
Any other questions for Mr. Koski? It doesn't sound like it. Mr. Koski, thank you very much for taking time to be here and talk to us. I really appreciate getting some insight from someone who's been in the industry for a very long time and seen it roll out other places. So it's very helpful. We really much appreciate it.
Thank you. And if I can be a help to anyone going forward, please don't hesitate to reach out to me or anyone from our staff or Jason. I'm always happy to have these types of conversations. It's never a dull moment for sure. I appreciate the time. Jason, if it's okay with you, I'm going to drop off too. Unless you'd like.
I'll leave that up to the board, but thank you, Lewis.
Oh, absolutely. As far as I'm concerned, we appreciate you being here and may pick your brain again in the future. Thanks.
You bet. Thank you. Rusty really enjoyed the back and forth too. Take care.
Very much, sir.
Bye.
Dr. Takubo, are you still there?
Yeah, I've been listening and very interesting. I guess a couple of quick comments I'd have is a lot of this stuff that has been discussed is extremely important, but I'm sure it's already been codified. And so what I would think would be the reasonable approach, because this is a mammoth of a topic, and we certainly want to get it right, is to just look at the existing code, because all that stuff, especially people that's had it for a while, like Colorado, they've, I'm sure, gone in and made multiple amendments over the past 10, 20 years, to however long they've had legalization, and there's a reason for all those. So I would start with that, and I would think that would address a lot of the questions and concerns that you have here, and then maybe do the same for a couple of the other states. And everything that they're doing in Colorado doesn't necessarily fit in West Virginia, but most of it probably does. And then just kind of do the research. I mean, I've learned a lot just listening in on this call, because I think if you guys as a board come with the regulations that you want to put forward, and you just have reasoning why, because all these questions that were brought up here, I'm sure are going to be brought up for the members of the legislature, but just almost like in medical field, we have levels of evidence, right? So in category A, B, and C, for example, recommendations. So if you say, here's what we're wanting to propose and why, when these guys go to asking questions, you'll be able to head those off pretty quick with explanations as to why you feel this is the best fit for West Virginia, and maybe based on what other states have done, yada yada. But that to me seems like would be the best approach. I know that medicine, I've said many times, is a bipartisan issue. So once you guys get all these recs together, getting a few folks, leaders from both sides and both houses, and maybe meet with all of us in one setting to get us on board, and then maybe we can do a little bit of the lift for you by going and educating the legislature on these topics, so that you're not having to spend the exact same speech in multiple committees. And again, this is a big topic. So do you guys have a rough idea as to when you are planning on the date that somebody can walk into a dispensary in West Virginia and buy medical marijuana?
I think that's a question for frame with the cannabis office, and hopefully, I'm hoping we do have, or we're close to where we know an actual date.
Yeah. So Dr. Takuba, I would estimate late fall. Right now, industry is in physical construction of the facilities, and then of course you have 3 to 4 months to grow at least the first batch of plants. And assuming that they get a harvestable crop, that would put us in the late fall time frame at the earliest.
Yeah, so you guys really don't have a lot of time left to kind of be getting all this. It really needs to be in place before a go live date. So I'm sure that you'd have enough legislators involved that would once you get your framework, or if you want our help, I could probably even round you up some guys that would help you, so that we're drafting all this and trying to get it all right in the first go round as much as possible, so that I would imagine you would have to have a special session or something, or unless you guys have broad enough rulemaking authority to cover all the topics that were covered. But I mean, even some of the things I heard. So for example, when you're talking about all this home grow, and like anything else, you're going to have people try to go around and abuse the system, and for those naysayers that don't believe in medical cannabis, they're going to be looking for examples to show, well, this is why we shouldn't have done it. But I mean, even into the penalty and criminal sections, if you're talking about people growing with intent and trying to sell and are selling, and those things have to be different than possession, which has to be different than being possession with a card, without a card. So do you guys feel you have broad enough rulemaking authority already to take care of all those issues? Or
so I'm going to jump in again real quick, and I'm going to give my I'm not a lawyer disclaimer that I give 10 times a day. But the board is a separate entity from the Office of Medical Cannabis. The Office of Medical Cannabis and DHHR has rulemaking authority. The purpose of the board is to make recommendations to the legislature and have those changes be legislatively enacted. Certainly DHHR could look at recommendations from board also, but the board itself doesn't have any rulemaking authority.
And Senator, this is Jesse Forbes again. I just jump in that, yeah, that's unfortunately, I can't take my lawyer hat off. I keep trying. Nobody will let me. But echoing what Mr. Frame's saying, you know, from our perspective on what we've had presented from DHHR to us really since this process began, it seems they do have, you know, the rulemaking authority in place, tweaks that you all made in the legislature in place to get this product out and really make it live. I think what we're kind of focused on from the board right now is, you know, what additional tweaks can be made to make this better for patient access and affordability, and how can we help the patients that are there, and also how can we help the industry, because if there isn't an industry that's viable or that's competitive, then there isn't going to be anything there for the patients. So that's kind of from our perspective, is we're trying to think of ways that you know, we can make this better, which is one of the concerns I kind of brought up at the beginning is, you know, we don't have a live program out yet. DHHR has you know, advised us over the last several meetings of, you know, when that might be, and now we're hearing it's probably late fall before the product is in patients' hands. And so there's some concern of, do we make recommendations at this point that go back to the legislature without knowing how this program is really going to look for the businesses and for the patients and all of that as it rolls out. But, you know, from our end, we're just trying to look at ways that we can make recommendations to the legislature that make sense. And I appreciate your comments of trying to look at these other states. I think that's why it was great to have Mr. Koski here. So, you know, and we invited at the last meeting and to try to get folks from other places to come in so we don't reinvent this wheel. Because like you said, most of this is likely codified in another state. And we have the benefit of taking from all of those other states and kind of picking the things that hopefully will make sense for West Virginia and are backed by those other states that have already tried it and maybe tried things that have failed and tried things that have worked. And so hopefully we can take the good parts and kind of present that to the legislature, and then you guys can decide if that ultimately makes sense for the citizens. So I appreciate your thoughts.
Sure.
Clarification on one thing. One of the other recommendations that I've proposed is to get rid of the list of conditions and open the program up, doctors to recommend cannabis to any patient they think could benefit. Is that something that the DHHR has the authority to do through the rulemaking process, or would that also have to go through the legislature?
No, and again, I'm not a lawyer, but that's codified and that would take legislative action.
I know there was some talk at one point about maybe trying to find a way to expand rulemaking authority either to the board or to DHHR to try to make that maybe ultimately easier, where we could put things in place and then take those to the legislature for approval. And I don't know, Senator, if that's something you guys have discussed or heard about. I wondered if that's something that was getting any traction at the legislature.
I can tell you on that standpoint, I've had a bill the past couple of years that try to expand those and try to do what you were saying. The issue is, is that physicians can't legally prescribe marijuana. They're right. It's Category 1. There's Schedule 1. There's no guidelines. There's no dosing. There's no, you know, that type of research or study. So we've treated this much like a handicap placard. A physician can only say, yes, you have these conditions. I'm a physician. I'm certainly able to do that. And then it's up to the DHHR to provide the card to let you go get it. And so that was a way of protection for physicians too, so that, you know, DA or somebody didn't try to come after a physician once somebody's in a car accident, they had marijuana in their system. And then of course, you know, the attorneys would try to go after the docs and try to say, well, why'd you let them do this? Where's your research showing that, you know, you should have allowed this? So all we were saying is that the legislature codified that here's some conditions. Now I try to broaden those conditions because I agree with Rusty, they're way too narrow and focused, but that bill always dies in the House. So I think what that tells you is you have to be a little careful, because I think this thing's far too down the road that it would ever get reversed. But you do have a lot of people still in the legislature that are adamantly opposed to marijuana, and so I'm not sure how you could kind of go around that without legislative action, but you know, that's why the lawyers are smarter than us. They can figure sometimes some loopholes, but I just throw that out there for the group to discuss.
Jesse, the way the bill was written this past session, basically it took away the need for legislative action. The way it would have worked is the board, you guys would have made a recommendation to add either a new form of medical cannabis or a new serious medical condition, and that bill would have enabled the DHHR to add that to the acceptable list without having to go through the legislature. But again, as Senator Kubo said, that bill failed.
I understand. It seems to be too, one thing we've got to just kind of be cognizant of is, I keep getting back to it, we don't have this industry actually rolled out. And, you know, to get into what the senator's comments a little bit were, is there are folks in the legislature that are still against this type of program. And, you know, one concern that I've had now for a long time is we need to get this industry on the ground and rolled out so we can help people. And I think it's easier to tweak it at that point when it really is an active industry providing things to patients. You know, so that's one of the concerns I had at the last meeting about trying to make a recommendation. Then I realized if we make a recommendation, I mean, we're likely not going to be in a position where there's going to be any action until the next session next year. So, you know, it may not be as big a concern right now, but that is one thing that I think this work group needs to think about, and the full board needs to think about, is what do we recommend now versus talk about and try to get lined up for the next session after the industry's kind of rolled out.
Yeah, that was kind of what I was alluding to about having different categories of evidence. So when you talk to other states that have done this, you know, it would be nice to not have to, you know, baby step 3 or 4 years of something that we should be doing right now, that when it does happen, everybody's going to be fine with it. But so to kind of leapfrog and get us up to speed a little bit, that's why I was saying maybe if for example, you had seen where some other states kind of tried to baby step into it, and they all ending up at the same place. And even though that may seem like a big leap to some of the legislators, if you're up there testifying, you can just explain, well, we were concerned about this, but after research, you know, talk to these amount of states, everybody kind of keeps coming to the same endpoint, which is this is where we need to be. So therefore, that's why we made the recommendation that we did. And I think if you do that, you'll get a lot more buy-in, especially if everything stays patient centric. So you're always explaining why this is going to help the patient. And then when other states, you know, did things, everything finally led to whatever final rule or whatever, that it was all because it helped the patients. And so I think you'll get a lot more people and traction and get this moved along a lot further if you kind of take that approach.
To that point, maybe, you know, if the board, if the feelings of this board is that we should wait until industry rolls out before we start, you know, looking at potentially recommending home grow. You know, maybe there's something that we could do sooner than that. You know, maybe we could recommend that the legislature acts in special session, or, you know, sooner than later, to get rid of that mandatory minimum. Because when we talk about facilitating better patient access, I mean, the truth of the matter is people have been using cannabis for a lot longer than the legislature had ever even thought about debating this issue. They're using it right now. And I'm really concerned that, again, we're going to have patients who are legally allowed to use this medicine, but they get caught growing a plant that they may not have had access to otherwise, and they're going to go to jail. So I do think that, you know, maybe that's something we could look at. I think we also need to look at immediately taking the steps, the necessary steps to advocate for reciprocity agreements to, you know, with our bordering states. But again, we've got these patients who are living on the Ohio border and on the Pennsylvania and Maryland border. They have access to medical cannabis. It's not legal access, but they're getting they're getting cannabis from these states and risking their freedom, bringing it in for a program that they're going to be legally allowed to use here. So maybe I'm just looking at what steps can we take now to ensure that we're not going to have patients going to jail for using this medicine.
So Rusty, let me touch on the reciprocity real quick. For better or worse, the reciprocity requirements are also codified, and it's limited to terminally ill cancer patients. So there is difficulty there also, again, with the necessary legislative action to change that.
What is the penalty right now for if a person has plants? What's the cutoff? What Rusty? What is the issue?
We've got a mandatory minimum of 1 year in jail for any cultivation. If they get caught with a seedling, and
okay,
they're going to jail.
Any cultivation at all is where we're at right now. Okay. Well, we have another meeting with the full board in on June the 24th. I don't know that we have something that like a recommendation that our subgroup has, except that we've discussed this and present that to the full board and see if other people have any other recommendations. In the meantime, potentially research this a little bit more before that June the 24th meeting. I don't know that we can make a recommendation today. Jesse, I'm trying to help you out, because it's like, well, normally we see if we have a recommendation to take to the full committee, but I don't have a suggestion about how to do that, except that we need to make sure that they know that we are discussing this and we're researching it.
Well, I think a couple things. I mean, I think we definitely need to report back to the full board, what we've heard from Mr. Koski, the information from Senator Takubo and his thoughts, and maybe with the full board meeting, Rusty, you could present a more detailed proposal of what you're talking about, so that we know exactly, how many plants, what's the access, what is the testing going to do, so that if we want to take an action at that point to vote on it as a full board, we're certainly more informed than we were. We could also look at the reciprocity issue. I think these are all issues that the full board needs to take up because they are serious issues for the patients. And that, the thing we have, which is both bad and good, and bad in that this is not already rolled out and we're not already helping patients, but good in that we have a little time, is that we do have some time here. I mean, we're not, the next legislative session is some time off. The industry has not rolled out at this point. By the time we get to the next session, it's going to be a live industry, and we're going to be in a position where we'll have more information to really provide. And so, my thought is kind of echoing what Joe's saying, is that we from this meeting, we go back to the full board with a report of what we've learned and what we've heard, and perhaps Rusty, if you would, present a detailed idea of exactly what this looks like in terms of a change to the code to allow home grow, based on what we're hearing, and I think there's no reason we shouldn't report to the board that the issues of reciprocity and cultivation came up, because as Rusty said, I mean, we're talking about, cancer patients, and are we going to subject them in this state to a felony conviction and a year in jail, because they're growing something at home that because of expense or whatever other reason that they could get in a store somewhere? That doesn't seem to add up, and doesn't seem to help patients. So, I mean, it seems like something that we could ultimately make some kind of recommendation to the legislature on. But I don't know that, I kind of agree with Joe. I don't know that as we sit here tonight, we're in a position to make a recommendation to the full board that yes, we want to recommend home grow, because I don't know that we have it kind of lined out the way Koski recommended that we do, and the way, Rusty, you've talked about doing, and the way the senator, look at other states and make sure we've got really something that backs up exactly what each portion recommending the code change be. So that's my 2 cents.
Yeah.
Yeah, I agree with both of them. I'm right there with you. I think that's fair. I can definitely put that together. If you want, I can craft a piece of legislation that does just that and have that ready. But I will say that, I truly appreciate everybody's work on this. I appreciate everyone's willingness, of course, to have this discussion. If I had it my way, we would have recommended home grow at the very first advisory board meeting. But I understand that, there's a lot that goes into this, and I just want to thank everybody involved. Jason, thank you for inviting Mr. Koski into this conversation. I think that his insight was absolutely crucial, and same thing for you, Senator Takubo. I truly appreciate you being a part of this discussion, and I'll do anything I can to help move the ball forward. So if we need to wait and put together a proper proposal or whatever and submit that to the full board, I'm more than willing.
Marijuana are of the mindset that if it's going to be legalized, then an individual should be able to do something for their self, and that I can tell you that much. And then the second thing would be, legislature doesn't meet again until January. However, we're going to be having interim meetings almost every month, since we're kind of backtracking and making up for what all was missing during COVID. But if you guys along the way see, especially if you're talking about going live in the fall and you're seeing something that could really create a legal mess for somebody, and you especially have solutions for that, the bill that I've tried to kind of push out to kind of hopefully clean things up, and I was trying to help Jason along a bit, and I think some of the stuff he was telling me that there's already in rulemaking, but the whole point of all that was just to try to open and clean things up for you guys a little bit. But it probably would have much better chance of going through if it was a governor's bill, and it can be done during special session. So if you guys are getting closer to start date and you're seeing, pretty significant issues and pitfalls that you don't want people to fall into, getting those ideas down to the governor's office. And while we're already in for an interim meeting, it would be easy to hold special session for that particular topic, because that's going to be big news when West Virginia gets ready to go live, and the cameras are going to be at all the dispensaries and people that are already getting their cards. And so it also is an opportunity to really point out to people what those pitfalls are. So for example, if somebody is growing at home, all of a sudden they've got a card, and now we're making them I guess they're a criminal now if they're growing now, but they think they would be legal at that point and be a criminal. But so that we don't do those kind of things to people, we can always do that in a special session right before things go live if we have that information. So just something to be thinking about as you guys discuss all this stuff. But getting it to the governor's office and just letting him put it out as his bill in special session would be probably much easier and more of a guarantee that all goes through.
Just one other comment. When Lewis was talking, one of the quotes was, "There's already an industry in West Virginia," and so these stores that are selling forms of CBD oil now, I don't know whether he was talking about that group that has that where there is some access to certain levels of CBD oil, or was he alluding to now we're going to have these other people that are here in West Virginia to be dispensers in the fall?
Joe, I took it to mean he was talking about the black market and folks that are selling this illegally, which has been here.
Okay.
I think you're right about that.
virtually all of our lifetimes and is going to be here after this rolls out, and
Okay.
doesn't think they can go buy this stuff, around the state, is just kidding themselves, because there's people selling this stuff as street drugs. But that was what I got.
Right.
That was
Okay.
but maybe
Well, it was just an interesting comment. And
Yeah.
I wanted to make sure I got some clarification on it.
that's the way I took it. Now, maybe he was talking about something else, and maybe someone else has different thoughts, but that's the way I took what he was saying.
Yeah, I think you're correct. Mr. Forbes, I just want to point out that we are at 7:20. I don't think Zoom will boot us out at 7:30, but it sounds like you have a path forward with Rusty and the home grow proposal as far as
Yeah, we're all very appreciative. I'd like to really thank Senator Takubo for taking the time to be here. It's very helpful to hear, what the legislature's up to and what your thoughts are. And we appreciate you coming and talking to us. And, as we work through this, we'll try to make recommendations to you that make sense. And if we see something, as you mentioned, that's going to be problematic as this rolls out, again, we're an advisory board. We're all serving on a volunteer basis here, but we do get regular updates from DHHR as to what they're doing, and we're trying to make changes and recommendations that make sense for the patients in West Virginia. So we appreciate you coming, Senator, and talking to us. Thank you very much.
Yeah.
Sure, glad to help. And if I can ever be of service, you guys let me know, and I'll go ahead and jump off so you guys can finish up. But thanks for having me.
Thank you, sir.
Thank you, Senator.
Rusty, what do you think? It sounds like we're all in agreement to make the presentation to the full board as we discussed. Do you want to maybe reschedule that next proposal that we're talking about for the next subcommittee meeting? Would that make sense? Or is that something, if it's something that you think we could loop into talking to the full board about, but I think it makes sense to present to them. So what do you think? It was your proposal.
Well, I definitely think, it definitely deserves, a proper discussion. I don't think that we have the time to jump into it tonight. And I do think that the work group needs to discuss it before we present it to the full board. So I'm more than open to having another meeting focused on that. If you are cool with that, I'm definitely okay with that.
We have 5 weeks before the next full meeting. If you want to do it before then, I just need some time to set up the public notice.
Okay.
Okay. Maybe you could send it out, Jason, and we'll try to see if we can get it scheduled before then with everybody's schedules.
Yeah, that's fine as long as you guys are willing to do it.
Yeah.
And I don't know if
I think
we need
you
a
need to let-
vote. I don't know we need a vote of the subcommittee here, but is everyone in agreement? And I guess maybe I just take what Joe said as a motion. I believe it was, wasn't it, Joe, to allow us, present this? And are we all in agreement with that idea that we won't make a formal recommendation tonight? Instead, we'll make a presentation at the next board meeting on these issues. Rusty will put together a more sort of comprehensive and detailed potential legislation on it, and we'll present that at the next board meeting. Is everybody in agreement with that?
Yes.
Yes.
Anyone opposed? All right, and I think that means, well, Rusty, did you second? He nodded. Second Joe's motion on that.
I did, yeah.
Okay, all right. We had a second by Rusty. Everybody's in favor. Nobody opposed. I know we have the public here. We don't have a ton of time left, but I, as far as I'm concerned, we can listen to everybody, and let's just give everybody a minute to talk and or comment however they wish, either through the chat, which I've seen has been going, or not. So if there's anyone from the public that's logged on, we really appreciate you all being here. Again, you've heard, but we're a subcommittee of an advisory board, and we make recommendations ultimately to the legislature. The law has to be changed by them, and DHHR has to implement that law, which is what Mr. Frame's office is doing, who's here. But we really appreciate the public coming on and talking to us. We're a volunteer board. Help the best we can, and we appreciate you folks coming in. So anyone from the public that wants to address us or tell us things that you'd like us to kind of look at or have thoughts about what you've heard, please just go ahead. Identify yourself in the chat window as Mr. Frame indicated, and then let's hear from you.
Yeah, please just type just your name in the chat window and we'll open up your mic. And hey, Jesse, a quick question real quick. Are you getting my text messages?
No, sir, I did not.
All right, I must have your phone number wrong then.
Okay. Well, we jump off here, we'll make sure we've got it correct.
Yeah, if you don't care, would you mind emailing it to me or something?
Will do. Sorry about that. I know I had all those technical difficulties in the beginning, so you were probably trying to get a hold of me, and I apologize.
No problem. Thank you. Okay, Crystal, looks like we have Amanda that wants to speak.
Hi, Amanda. Jump right in.
Hello, my name's Amanda Vesnett. I'm a disabled veteran. On the topic of, they said people are already medicating on the black market. I think what we didn't take into consideration there is there's a lot of people who are going without medication because they can't afford the black market either. And they're not going to grow because they're afraid of the consequences. Another issue that we're seeing among patients is everybody's getting these card approvals already, but there's no product ready, and they think that's going to protect them from prosecution. Is there going to be any extension on those expiration dates?
So, Mr. Forbes, I can take this real quick. Amanda, there is no plan to extend the expiration dates for the cards that have already been issued. Certainly, if it does present financial difficulty to the members of the public that are applying, there is a method for them to avoid paying that fee associated with the card. But there is no plan to extend the expiration dates of the cards.
Okay, that took care of that question. But yeah, I did want you guys to keep in mind that there are patients that just are not medicating because they cannot afford the medication.
Thank you, Amanda. We appreciate your comments.
Again,
I think take into consideration.
All right, Crystal, looks like Stephen wants to go next.
I think we just got a message from him. He's got an internet issue, maybe. Yeah, Stephen just typed in the chat that he's got an issue with his internet, and he'd like to ask questions using his voice another time. Well, Stephen, thanks for listening and coming in, and feel free to come to the next meeting we have of the subcommittee, and we'll have a full board meeting coming up. So please attend, and we'd like to get your comments then. So thank you.
And you could also
he did ask a question.
Oh, I'm sorry.
Oh, is there a question
in the chat? He had a side question right at the beginning. Do these rules and concerns exist legally for growing any other plants in your home? I imagine people are concerned because inexperienced growers may damage property with a question mark. Even so, is it necessary to create a law to grow one plant when anyone attempting such a project with any plant has the same issues as with cannabis. Always trying to understand the ultimate reasoning for the burden on the citizen for something that can be grown in a window box. I don't know if anybody has a comment about that.
Yeah,
Yeah, I think that
well, I
gets,
just comment, appreciate your typing that in, Stephen, and Joe for reading it. You know, obviously, I mean, we're focused on the medical cannabis issue, and in doing that, you know, we have to look at the existing laws and you know, like it or not, growing a tomato plant is one thing. You know, you risk running afoul of criminal laws and everything else with growing cannabis. And so I don't think, I just saw your question. I don't think it's a naive question at all. I saw your comments, and I know that sounds naive. I don't think so. I think your point's well taken. That, you know, I think at that point when you typed that in, we were discussing even some, you know, municipal zoning issues and things like that. So, I mean, obviously, you know, these are things that can be done in someone's home, and it sounds like can be very helpful for patients. I think as a board, we just want to make sure that we get this recommendation, if we're going to make it correct and done in the best way to help everyone, so that we can, if we present it to the legislature, that it is something that's well received and ultimately helps patients and deals with both existing law and potential issues if we change the law. So thanks, Steve. I don't know if anybody else had a comment on that. If not, maybe we'll move on to the next person.
Any other members of the public that want to comment, please enter your name in the chat. And Jesse, I think that may be, no, there are other folks.
Let's just give it a minute and see if anybody wants to.
While we do that, or while we wait on that, I would like to make a comment. I really would like to see the policy and procedure part of this make a strong recommendation to the remainder of the board to make a strong recommendation to the state to open up this diagnosis list to diagnoses that are, I mean, we continue to talk about remaking the wheel. And, you know, we look at other states that have done this for 2 decades as our point of reference. And, you know, we're leaving off thousands of patients that suffer daily that could benefit from medical cannabis. And, you know, the narrowing of this list is going to be the ultimate demise of this program if we don't take action and if we don't make recommendation. I think right now the numbers stand at around 12 to 1,500 patients have registered in the state of West Virginia, February the 3rd. 1,500 patients is not going to bring medical cannabis to West Virginia. I think that we're being naive as a board to believe that 1.8 million people are going to matter to corporate medical cannabis companies. And I think that without expanding this diagnosis list, we're going to miss patients who would benefit from the treatment. We have years of studies that say depression and anxiety and, you know, other, you know, what others feel are routine diagnoses are not on this list that states surrounding us, and, you know, as far away as California, Oregon, Colorado, and we know it, that it works and it benefits. Without opening this diagnosis list, we're basically putting a stranglehold on West Virginia medical cannabis program. I really wanted to speak out against that because, you know, as a practitioner and as a certifier, I have patients that call me every day. I get at least 15 calls a day that want to know why I can't certify them for this. And I understand that it's the limitations that the legislation has set forth, but it doesn't make it right. And when a you know, the Senate leader sets and says, don't remake the wheel, we have to take that advice and run with it and say, look, here's the wheel. You know, we're creating a square wheel in West Virginia when we really need a round one.
I could not possibly agree more. Thank you for
Yep.
saying that. This is something that I've hammered the legislature over since the inception of this program, and it always makes me feel better when I hear medical professionals echoing the same sentiment, because you're 100% right. And also, when you look at this from an industry standpoint, industry should want that list of conditions going, right? Because you straight up nailed it with the amount of patients that we have registered right now. That is nowhere near enough to sustain the market, to sustain this industry. So, and again, it facilitates better patient access. I speak with people all the time who have conditions that aren't on that list, and even when when this program is up and running, they're still going to use cannabis because they've seen such a benefit from it. But they're going to have to continue utilizing the black market. And I think anything we can do to end that is definitely the right step. So thank you for saying that.
And I realize that certification isn't prescription, but certifying a diagnosis that may not be on some random list doesn't, I mean, just me certifying the diagnosis is the same protection, that they talked about. Oh, this list protects doctors from malpractice and I mean, in the grand scheme of things, if I'm just certifying it, there's no real protection needed. We have the medical evidence. We use medications off label in every facet of my profession. And I just think that for us as a board, not to step in and say, look, we're here for patient advocacy, or at least that's what I'm here for. And, if we don't advocate now, this may not get rolled out like everybody says it's going to. It may not be late fall. I'm telling you, I've talked to people in this industry. If we don't have 10,000 patients on that list, late fall won't even come.
I'm hearing the same thing.
Well, guys, I kind of appreciate it. I think it all makes a lot of sense. I think that's why Rusty had suggested, this as an agenda item. And I do think we need to have another meeting where we can hash this out in a way where we present something that the legislature might, first the full board listens to, and then the legislature listens to, because, been listening to Rusty, as you just said, you brought this up, I guess, Rusty, about every time the legislature's been in session, right?
Oh, yeah.
And hadn't gone anywhere. I mean, unfortunately, hearing what the doctor says, it sounds like there are other conditions that need to be looked at. The issue I think this board has is we have to do this in a way that ultimately gets action and isn't just us making a recommendation that doesn't go anywhere. So, I think everything you've said it warrants a lot more discussion, and to get us in a spot where we can make a recommendation that makes sense to the legislators, not just to the Senate side. But I think we've got, you heard Senator Takubo, that there's a lot of folks in the legislature that are against this program, and there's bills died on the House side, and so we've got to have something that is going to resonate up there if we make a recommendation on it. And so that's why I just think it makes sense we get another board meeting set where we can spend the kind of time we spent tonight, and get something a little more detailed to present to the full board, and then ultimately, if the full board decides to the legislature.
Absolutely, I agree.
Great.
And I would be more than willing to gather some information. I also certify patients in Pennsylvania, as I hold a medical license in Pennsylvania, and I live in Morgantown on that border. And we just have to look to our neighbors to the north to understand that program grew at a snail's pace and nearly choked itself to death until they opened up that diagnosis list. Once they opened up that diagnosis list, it became a beneficial flame for patients across Pennsylvania with relatively minimal negative feedback from patients, providers, growers, and from the industry as a whole. And so, I would be more than willing to gather some information in regards to how that program, went from a small program with a much larger population than ours to a viable growing program as it is today. And so,
Yep.
I'll have that ready the next time this group meets.
Yeah.
I think that'd be great because
That'd be great.
that's what I'm talking. I think we need to be able to have information that backs up why we're making the recommendation we're making.
Absolutely.
So it's just right there for everyone to see why we're suggesting it and why it's supported. So if you can get that for the next meeting, that'd be great.
Certainly. Yes, sir.
And just one final comment too. The black market. I mean, we're seeing in treatment, people that have marijuana that's laced with fentanyl and other substances, and I mean that's a big issue. I think that we could also sort of alarm with the legislature is that it really is a safety issue with the kinds of products that are out there on the black market right now.
Jesse,
that makes sense. Go ahead.
Sorry to interrupt. I was just going to tell you that I think we do have a couple more folks that want to talk from the public.
Let's hear from them.
All right. Crystal, can you unmute Amanda?
Hello, I just wanted to jump in and say, Rusty talked about reciprocity earlier. I mean, is that something we could actually push for? Like the senator insinuated they could meet during one of their special meetings?
Mm-hmm.
No, I think that's absolutely something that we want to discuss and potentially make a recommendation on. I mean, I think what the senator was getting at is they have interim meetings, the legislature does, where they're not officially in session and they're not actually acting on legislation. And then ultimately the governor, only the governor essentially, can call them in for a special session where if there's one particular issue that needs to be fixed on something, whatever it is, the governor can call the legislature in for a special session. Those are rare, and they're usually for sort of big ticket items. But the interim things are things we could present at an interim committee meeting or something like that. And I think this work group certainly is interested in exploring reciprocity issues and trying to help with that for patient access. So I hope that kind of answers your question. I don't know if anybody else wanted to jump in. I sort of just tend to do that.
I think you nailed it.
All right, Crystal, looks like next up's Kevin Wall.
I just wanted to reiterate the list of medical conditions. It is hindering. And when I talk to my clients and they ask me what the patient numbers are, they're kind of disappointed that, we still haven't broke 2,000, in the medical patients across the state. And I think that's, it's kind of looking bad right now, especially being, the build outs for the dispensaries and stuff. The fear is that the dispensaries are going to be open. There's not going to be any patients there. So I think the list of medical conditions is a big hindering on that. I just wanted to support that. And another thing is, I think, I spoke to Jason the other day on the phone. Just getting it out there and trying to, educate people and let them know that this is up and running and you can apply for it, is something that I think we all need to volunteer that's in the industry to take the time to let the public know. So, but I just want to thank you guys for your volunteer, for your time and all the work and effort that you guys put into this stuff.
So I want to take just a second to address this. I know patient numbers have been brought up a few times. I just want everybody to know that DHHR is in the process of embarking on a public awareness campaign to make sure everyone out there that is eligible knows at least about the possibility of medical cannabis. So we're going to be pushing pretty hard on that over the next few months to, again, try to address any awareness issues that might be out there.
Yeah, and one thing I would just like to just make a comment. for the people that may be watching this recording or, tuning in, I just think that, we've got to give credit to everyone at the Office of Medical Cannabis, everybody that's working to get this program up and running. I know that patients are frustrated with the slow rollout time, but you have to understand that with all of the issues that happened with banking and, to get the vertical integration bill passed, there's been a lot of hurdles that were thrown up, not just in the path for patients, but also, in the path of the Office of Medical Cannabis. And there were a lot of barriers to get to where we are. And I do think that it's important that folks just kind of calm down and realize that the people that are behind this industry are working every day to try to create a proper medical cannabis program. And I just think that, folks need to realize that everybody's working hard to get it done. So stick with us.
I appreciate that, Rusty, and that's a good point. I do hope everybody remembers that due to those larger technical issues, this program really just started implementation fall of 19. I know the law was passed in 17, but again, due to those issues that you mentioned, implementation wasn't possible till fall of 2019. And again, I know our industry partners are working hard out there to get their facilities ready as soon as they possibly can. They definitely want to get there as much as anybody else.
Sure.
Hey, I want to say to Kevin too, thanks for your comments. And the more industry folks that kind of explain to this group and the full board what they're seeing and what the issues are, I think the better. I mean, obviously we always want to hear from patients and the patient perspective, but as was said earlier, I mean, if the industry's not there, then there's no way to help the patients. I mean, no clear way and no large format way. So I think the more information we can get from what the industry folks are seeing, the better. We got any more comments?
I don't think so, Jesse.
All right. Well, with that, I guess I would entertain a motion to adjourn. Unless anybody else on the board, anyone else has any other comments to make?
I move we adjourn.
Rusty's smiling. That must be a second. All right. And we're all in favor. Nobody's opposed. I guess that ends the meeting. And thank you, everyone, for your time. I know we've been sitting here now for almost 2 hours. And thanks to the public for coming and our speakers. Hopefully this train is moving forward and is going to get to the station where we're really helping people. So let's just keep it up. And Jason, if you want to send an email around for that next meeting, we'll try to see if we can get it scheduled before the full board meeting. Hopefully we can. If not, maybe we'll have to schedule it shortly thereafter, but let's just see what we can get done.
Yeah, we've got plenty of time. Shouldn't be an issue.
Great. All right. Thanks, everybody.
Thank you.
Thank you.
Thank you.